of my moderating. Now we have four international speakers, no? Two of which are regional experts from Southeast Asia. One, an international expert from across the pond from the United States, and one from the international state of Davao. No? So our first speaker is Dr. Chaisiri Chaichankul, Sawadikap, from Thailand. He will be presenting the radiological assessment of ASD, regional, global, and sagittal, spinopelvic, and coronal parameters with clinical example. Dr. Chaichankul is presently a consultant from the Pramongkutlau Hospital in Bangkok, Thailand. He had a spine fellowship at the Tohoku Central University, as well as spine fellowship at the University of Hong Kong, and the Department of Orthopedics at Gangnam Severance Hospital, Yonsei, Seoul, South Korea. So may we hear from Dr. Chaisiri's lecture.
Hello everyone. This is my honor to be here. My name is Chaisiri Chaichankul from Pramongkutlau Hospital, Bangkok, Thailand. I would like to present radiological assessment of ASD, regional, global, sagittal, spinopelvic, and coronal parameters with clinical examples. According to such a limitation of presenting time, so I intend to give all of you as a scope of this. This is my disclosure. This is about my talk today. Adult spinal deformity, or ASD, has a profound impact on patients' health-related quality of life. It is comparable to many chronic diseases. There are a large variety of spinal deformities which caused by various etiologies. In aggregate, the data suggests that patients with ASD, including the elderly patients, benefit from surgeries. So, we can see that the number of ASD surgeries have more than doubled in the past decade, as reflected by the increasing rate of publication of ASD surgery. However, nearly 70% of patients undergoing ASD surgery were affected by one or more complications, which included the period of intraoperative, perioperative, and post-discharge. Notably, mechanical radiographic failure is one of major problems. Poor alignment usually gives a poor long-term outcomes. Unrealistic deformity correction of both sagittal and coronal spinal targets cause worse outcomes. To achieve the successful outcome and minimize the complications of ASD surgery, optimal spinal balance targets including global sagittal and coronal alignment with harmonious lumbar lordosis is one of the main goals of ASD surgery. Consequently, radiological assessment is one of the important steps to execute the proper management in ASD patients. Respect to spinal alignment, both sagittal and coronal, is a matter of the utmost importance. After the three corners concept acknowledged by Professor Lehuek in 2018, two-global spine alignment was assessed. This concept includes upper conus, which was neglected by previous studies, middle conus, and lower conus to indicate the full body alignment. And understanding the change of one regional alignment can have an effect to the other is very important. We call this phenomenon as chain of correlation. As demonstrated in this picture, you can see spontaneous increase in compensatory cervical lordosis following increase in lumbar lordosis and thoracic kyphosis, and vice versa, increase in T1 slope and thoracic kyphosis following increased cervical lordosis. In addition, compensatory mechanisms including physiological and pathological is another point that we should focus. In balanced spine, one can stand and walk for a while, but in unbalanced spine, one will lose of global alignment. In this slide, I want to demonstrate an example of patient with decompensated sagittal imbalance who presented segmental compensation with a hyperextended L4-5 intervertebral space. The compensatory mechanisms are implemented at the segmental, regional, global levels, and they are not all implemented at the same time, but are associated with different extents. To start radiological assessment, we should start from measuring pelvic incidence angle or PI, because the pelvis determines the position of the lumbar spine and hence of the entire vertebral column, as previously supported by the chain of correlation study. Other two parameters that we should measure are pelvic tilt and sulcal slope angles. These are dynamic parameters and show the patient's compensation reserve. Although we have number of parameters to determine the global spinal alignment, many of them omit the upper conus part according to the three conus concept. So recently, odontoid hip axis angle or ODHA angle, which characterizes the overall spinal balance, has been applied. This angle can be measured in 2-dimension or 3-dimension. In addition to ODHA axis, you can notice that more and more novel parameters to evaluate global sagittal alignment have been existed. And don't forget the coronal alignment, which is the one component of global alignment as well. Recent evidence suggests the impact of coronal balance on pain and functional outcome in unoperated patients. And there is a growing body of literature indicating that greater postoperative coronal imbalance is associated with increased pain, increased loss of function, and decreased quality of life. Please recognize that patients with coronal malalignment don't have many compensatory mechanisms available when compared to sagittal malalignment. Unlike measuring sagittal alignment, in measuring coronal alignment, there are many parameters to consider as well, both as the distance and angles. Two steps to integrate the above data before treating the ASD patients are: first, determine the value of the PI and the theoretical values of the spinopelvic parameters. And second, analyze the overall sagittal balance from cervical spine through lower limbs. There are lists of the must-know equations when we deal with ASD management. The first one is PI equal to pelvic tilt plus sulcal slope. According to the study of Hasegawa, commonly used Schwab formula, pelvic incidence equal to lumbar lordosis plus 9 is only valid for small incidence angles. And a multi-center study showed that radiographic and implant-related complications occur in 30% of patients who underwent surgical correction using these values. So, aiming to distribute more appropriate spinal alignment, Levick developed the formulas to determine theoretical values of the spinopelvic parameters. You can see that even though the formulas are quite complex, but if you deal with the ASD surgery frequently, you will use to them. Shape of the spine is the next one to execute the good long-term outcomes of ASD surgeries. At present, there are 5 types of curvature. However, this classification is based on the analysis of spinopelvic parameters, especially PI in healthy persons, but does not allow in pathologic spinal balance conditions. So, it is unusable in degenerative conditions. So, Sibley described the explanation of evolution of normal type shapes into pathological shapes, and this classification can help surgeons to look backwards estimate of ideal spinal shapes. Many studies try to fill the knowledge gap, which is the optimal lordosis distribution in ASD patients. However, no study can answer this question because of several inconsistencies. And about the question of how much is the optimal and ideal alignment target should be. Account for age, comorbidities, daily activities. There are too many debatable topics right now, and we need further research to fill our gap of knowledge. This is the latest study that determined the appropriate alignment targets by Lafarge, named Sagittal Age Adjusted Score for adult spinal deformity. This study claimed that it more effectively predicts surgical outcomes and proximal junctional kyphosis than previous classification. The next is case presentation. Case number 1. A 24-year-old Thai female presented with low back pain, progressive scoliosis, and radicular leg pain. Initially, we assess what is the driver of this deformity. In this case, the high-grade spondylolisthesis L5-S1 is the cause of presented deformity. We tackle at the driver of deformity, which is dysplastic high-grade spondylolisthesis L5-S1, by particular screw fixation L4-S1 with partial reduction and interbody cage placement of L5-S1. You can see that after the correction of driver of deformity, both coronal and sagittal balance was achieved. Case number 2. I want to show the effort of compensatory mechanisms which makes this patient have a horizontal gaze and erect body inside the cone of economy. The compensatory mechanisms include decreased cervical lordosis, thoracic hypokyphosis, and increased pelvic tail by retroversion of sacrum. After corrective spinal deformities with PSO-L3 was done, the regional alignment including cervical lordosis, thoracic kyphosis, lumbar lordosis, and pelvic parameters were improved. Case number 3. Show the compensated balance of spine. Alignment targets in this case was determined by age adjusted spinopelvic parameters. By allowing for a compensated balance, a simple surgery is recommended, rather than major surgery with a high risk of complications. A last presented case is a 65-year-old female. She had chronic back pain, neurological claudication with severe coronal malalignment. We perform corrective osteotomy and maintain the optimal alignment by kickstand lock technique. There is no standard degree of correction that would lead to a classification of flexible or rigid. So, the surgeon must rely on his or her own experience. Ultimately, the surgeon should rely on his or her own experience in determining whether or not the individual patient's deformity based on pre-operative planning. In conclusion, for the radiological assessment in ASD surgeries, analyze ODHA first, then pelvic parameter to find compensatory mechanisms. Pay attention to the optimal target values to restoration of harmonious thoracolumbar curve. Not only sagittal alignment does matter, but also coronal alignment does matter too. Ideal spine shapes should be considered in pre-operative planning prior to ASD surgery. And finally, define and give proper management to the driver of deformity. Thank you for your attention.
Wow, that was an excellent presentation by Dr. Chaichankul. Our next speaker is from Singapore, and he will be